Hi, I'm Elissa and I'm a medical educator in Lehigh Valley Health Network.
Okay, medical educator, but you're also a communication scholar, so can you explain that relationship a bit?
Yes, absolutely. There are now 3 PhDs in communication working at Lehigh Valley Health Network, and that has been made possible by grant funding through the Pool Trust Foundation, which is associated specifically with education for Lehigh Valley Health Network. Lehigh Valley is known for innovation and investment in their education of their medical residents. They are a academic community hospital. Mm-hmm. So unlike most places where physicians are trained through their residency, which are associated with universities, this is a fairly unique place in that it's a community hospital that is also involved in the education of residents and medical students.
Okay, so you're a communication scholar. These are residents and physicians. Tell me what you're teaching them or working with them about.
Absolutely. I actually have a joint appointment in the Division of Education, which looks at education for the entire network. So that is really interdisciplinary professional development for physicians, for nurses, for our respiratory therapists, physical therapists, our clergy. Everybody can be involved in that. And so I'm delivering some content there, but also doing a lot of help with facilitation of more effective communication practices. So helping to do better communication across specialties, interprofessional communication between physicians and nurses, and so on. And that can happen through a range of projects that we're working on. My main job, though, is working in the family medicine residency program where we train our family medicine practitioners, because that program is involved in a complete redesign of education for family practitioners called the P4 program, which is preparing the personal physician for practice. And there are 14 residents, that's why the P4. There are 14 residencies across the country that have been given permission to experiment with this training. And our training is actually the most extensive innovation. We're doing the most changes to the residency, and so they employed 2 medical educators to help more effectively train the residents, and then also to do evaluations. That's where the research part comes in.
Okay. And what kind of communication training do the residents get?
They are given what is called relationship-centered care communication training, which is a model of communication that really precedes us by about 10 years in that residency. The residency was founded on this idea that the relationship between the provider and the patient is absolutely central to the healing process. And there are a number of tools that they have developed and employed in that residency that form the basis of the residency training. One of them is called the clinical hand, which is a hand model with the different fingers, each representing parts of the interaction, which begins with the first step of negotiating the agenda. So recognizing that the physician shouldn't simply come in deciding what is needed for the patient visit, but should talk to the patient about that first before anything else happens.
Interesting. So in terms of evaluating the success of this communication training for residents, what is the success?
I think they've had great success, and I think in terms of developing the curriculum so that then this training can start to be transported into other residencies. It's early stages, we're only in the 2nd year of the intervention, but I think we're going to have some pretty good success. The residents come into the program usually with a passion for primary care, because that's why they're going into family medicine. It's certainly not for the money. But they don't necessarily have the skills. And so we begin, even in their first months, with videotaping them with actual patient encounters and having them review that with the faculty members to see how are they doing with building these relationships.
What about feedback from the patients who are participating?
Yes, that's a great question. That's one of the things that we're going to try to develop even more, is partnering with the patients to have them provide feedback. We have written feedback that we ask them to give, but I think it would be great if we could also have them provide feedback in the moment rather than the delayed feedback of the videotape. What's tricky is that we're not using standardized patients, we're using actual patients who are there to be treated, and often they want their prescription or they want their advice and then to leave. But we're also trying to build a strong sense of community in the different practices where we have our residents, so that the patients can feel more that this is what is coming to be known as a patient-centered medical home.
Okay. Well, as you train the physicians and the residents about communicating with their patients, are there any principles that you can draw to that would be of particular benefit to patients when they have communication with their physicians?
Absolutely. I think patients probably, anyone who's been to see a physician probably knows this, but there have been numerous studies done about the length of time it takes between when the patient starts speaking and when they're interrupted by their physician. And usually it's about, I think it's been extended now because the study's been around for a while and people know it, that it's gone from 16 seconds to about 20 seconds. So I think if patients realize that is a tendency, and also knowing that one of the ideals of the interaction should be more of a partnership with the physician, I think starting by knowing, for example, how to negotiate the agenda with the physician is a really important principle that patients can begin with. And even if they start the interaction by saying, I'd like to spend some time, I know that your time is short, but I'd like to spend some time before we begin talking about what the most important things are. And then listing all of the concerns at the beginning. Because one of the other things that we know about interaction is like the threshold disclosure as the patient's about to leave. And if the physician's doing a good job, they might ask, is there anything else that you're concerned about? The physician really wants the patient to say no. But sometimes the patient will bring up something like, well, I've been having this intermittent chest pain, which if that was brought up at the beginning of the office visit, that probably would take precedence. So that's one of the ways in which partnering sometimes with the physician and getting all of the information out at the beginning can really help for a more effective patient visit.
Great. Well, thank you so much, Elissa.
You're very welcome. Thank you.